Welcome to the Learning Intent series. I'm Jasmine, one of the registrars with the Department of Infectious Diseases at Singapore General Hospital. We'll be touching on the subject of osteomyelitis today. Osteomyelitis is an infection of the bone. For today's topic, we'll learn to recognize osteomyelitis in our patients and describe its pathophysiological process. We'll also review the investigations and the need to investigate appropriately and timely before treatment is started, to recognize common causative pathogens in the various hosts, the immunocompetent hosts, trauma patients, diabetic patients, and in patients with underlying hematological disorders, and also to discuss appropriate management strategies in such patients, which is often multidisciplinary. There's the combination of use of pharmacological agents, in this case it will be antimicrobial agents, as well as surgical strategies to manage osteomyelitis effectively. We'll touch on this. For the diagnosis of osteomyelitis to be made, it's often a combination of different modalities. First, you get the history and you examine the patient. That's the patient's clinical presentation. You'll also review the x-rays. You look at the culture results and also review histopathologic findings based on bone biopsy. We'll discuss the clinical presentation in this slide. Patients often present subacutely or with some chronic symptoms. The symptoms may be vague with no systemic complaints. They would only complain about pain, tenderness, redness, and swelling at the affected site. And in getting a history, remember to ask for risk factors. Identify common medical conditions in such patients, namely that of renal impairment on dialysis, diabetes. Ask for a history of trauma, and also remember to ask if they have previous history of known hematological disorders like sickle cell disease or the thalassemias. Also, ask about the mechanism of infection in such patients. On examination, you might want to look at the site of the infection, which might give you a clue as to how this problem might have occurred. Look for signs of chronic osteomyelitis. Would be things like discharging sinus at the affected site, and remember the complications of osteomyelitis. For example, in vertebral osteomyelitis, look for neurological complications. In the picture on the right, it's a patient with diabetic foot. He had a chronic ulcer and the infection extended and affected the bones. Following wound debridement, the wound was slow to heal. He underwent further surgical debridement, and this is a picture showing exposed tendons here. There's slough at the base. This is suggestive of osteomyelitis. If we could break down the topic of osteomyelitis in approaching our patient, I'll look at it at few broad headings or categories. First, we can look at the host. It would give us a clue as to how the infection might have occurred. In the young and elderly patients, infections are often hematogenous. For diabetic patients, they frequently have neuropathic ulcers or arterial ulcers. They may have sustained wounds to the foot which are difficult to heal, and there'll be contiguous spread of infections. Often, such infections are polymicrobial. For patients with hematological disorders, as discussed earlier, they have underlying sickle cell disease or the thalassemias. They are at risk of salmonella bone infections as well as streptococcal and staphylococcal infections. The site of lesion gives us a clue as to how this process might have occurred. In long bones and in the vertebrae, without a history of previous trauma, this is suggestive of spread via hematogenous seeding. If there's a history of previous trauma, then the infection may be contiguous to the site of trauma. And to remind ourselves again, osteomyelitis could be caused by hematogenous process or contiguous spread. And to get a definitive microbiological diagnosis, please obtain bone biopsy for cultures before antibiotics are started. And remember to review the duration of symptoms. Did it start acutely or chronically? When we talk about chronic osteomyelitis, frequently symptoms may have been present for more than 6 weeks. The duration of symptoms may influence choice of management, which we'll talk about in a short while. For hematogenous spread of osteomyelitis, frequently it's caused by blood-borne pathogens, and in such cases, the most common organism would be staphylococcal infections. They spread to the metaphyses, aseptic emboli forms, and then osteomyelitis develops. Such infections are often monomicrobial. Moving on to contiguous spread, it could be caused by trauma, or patients might have diabetic foot with cellulitis and chronic ulcers developing. The pathogen is frequently introduced to the bone. They could be organisms associated with skin flora, could be colonizers of the introducing agent, and often such infections are polymicrobial. Thinking about the classification of osteomyelitis, there are two broad classification systems. The Liu and Wattwagel classification is described based on the duration of symptoms as well as the mechanism of infection. For the duration of symptoms, as mentioned earlier, it could be short duration, acute presentation. Symptoms occur for less than 2 weeks, or subacutely, where symptoms occur between 2 to 6 weeks, or chronically. In chronic osteomyelitis, we talk about involucrum formation, local bone loss, as well as sinus tract formation. This is illustrated in this cartoon here. With the septic spot developing in the bone, there's inflammation, some bone dies, and this black dot here is called the sequestrum. In response to the bone inflammation, there's periosteal reaction. New bone forms, characterized by this brown annotation here, and that's the involucrum. The pus forms around the sequestrum and discharge through the cloaca, and that's your sinus tract formation. For the mechanism of infection, it could be spread either hematogenously or contiguously. For children, the metaphyses of long bones are affected, and in adults, we see osteomyelitis more often in the vertebrae. For younger patients who have contiguous osteomyelitis, it's often related to trauma and surgery, whereas in the older patients, there's an association with the decubitus ulcers, and there might be associated infected joint arthroplasty. The second classification is the Cherney and Maeder classification. It's based on the site of the infection, the host, we look at their immunological status, as well as some local factors looking at their vascular supply, the lymphatic supply, as well as problems with neuropathy in such patients. Such a classification allows us to think about managing the patient appropriately. It influences choice of management, be it just medical treatment alone or combined with surgical management. Stage 1 is medullary OM, characterized by this spot here. Often it's spread hematogenously. The treatment is then medical therapy alone with appropriate intravenous antibiotics. The second stage is where superficial osteomyelitis develops close to the bone surface, and often it's spread contiguously. For stage 3 infections, there's localized OM characterized by this spot here, and that's cortical sequestration. In diffuse osteomyelitis, frequently multiple spots are affected, and for stage 2 to stage 4 infections, wound debridement, antibiotic therapy, as well as reconstruction surgery may be required in such patients. In the workup of such patients, various tests are used. We start off with simple tests first. Often we'd like to obtain baseline ESR and CRP, and we trend such inflammatory markers along to monitor their treatment response. For blood cultures, it's useful in acute osteomyelitis and useful for hematogenous spread, where blood cultures are positive in 50% of the cases. Bone biopsy is especially useful. It guides and tailors the choice of antibiotic therapy for our patients. Remember to order bone biopsy before antibiotics are started, and we expect it to be positive in 87% of cases. And sometimes we look at the histopathology report. If chronic granulomatous changes are present, then we will be worried about TB in our local setting. For the radiological findings, various modalities can be used, but the cheapest and most commonly available is the X-ray. Osteomyelitis changes takes 10 to 14 days to develop. We look for lytic changes, and for chronic osteomyelitis, we look for the bony sequestrum, we look for the involucrum, as well as the cloaca. The MRI may be a very sensitive test to do, but remember to start off with the simple test first. Sometimes bone scintigraphy and the TAC white cell scan may be useful. Moving on, we look at the microbiology of osteomyelitis. And again, we go back to the pathophysiological process. Remember why this osteomyelitis develops in the first place. Then you understand the possible causative pathogens which may result in osteomyelitis developing. And also think about the host. For hematogenously spread osteomyelitis, in neonates, Staph aureus and Streptococcus species are reported. In the elderly, again, Staph aureus is the most common organism causing hematogenously spread osteomyelitis, and sometimes the gram-negative rods like E. coli may cause such infections. For patients with prolonged neutropenia, think about bacterial infections as well as fungal osteomyelitis. For hemodialysis patients, Staph aureus is by far the most common. For the intravenous drug users, well, any of the organisms could cause such infections. It could even be things like Pseudomonas species. Eikenella, it's mouth flora and it happens when they spit saliva and mix the drugs before shooting. Candida infections do occur. We talked about sickle cell disease earlier, and to remind ourselves again, Salmonella species may cause osteomyelitis as well as Staph aureus and sometimes the Streptococcus species. For contiguous spread of infections, it happens following trauma, and it could be skin flora, soil organisms, and sometimes nosocomial organisms if the infection is related to implants. For diabetic patients, again, it's related to skin flora. It's often polymicrobial, and we have to worry about pseudomonal bone infections. I go back to the pathophysiological process very often in terms of managing osteomyelitis. As you can see in this slide, it affects the choice of antibiotics. And again, with hematogenously spread osteomyelitis, it's often monomicrobial, and by far the most common organisms are the gram-positive bacteria. And for this, you can use either the penicillin, the cloxacillins, or the vancomycins, depending on the organism isolated, as well as the patient's allergies. If gram-negative organisms are isolated, either in blood cultures, or if you're worried about gram-negative cover, then remember to add in a gram-negative agent. For contiguous spread, the patients may have no vascular insufficiency, in which case such infections are caused by trauma, be it either via nail puncture, long bone fracture, or post-op sternal wound infections. And remember the diabetic patients with vascular insufficiency, in which case you need to revascularize the patients as well. That is part of your management strategies. Moving on to the choice of antibiotic therapy. Infections caused by contiguous spread are often polymicrobial, cover gram-positive organisms, gram-negative organisms, as well as the anaerobes, and choose your antibiotic agent that would cover all these three categories. I must emphasize again and again that for managing patients with osteomyelitis, please obtain microbiological diagnosis before starting treatment. If the infection is spread hematogenously, you have obtained appropriate blood cultures, which are 2 sets of blood cultures. They're positive and they're consistent with the infection, then you treat. If, however, the blood cultures are negative, it is wise to obtain bone biopsy. The choice of antibiotics is guided by microbiology. Your choice of antibiotic is as good as the organism you suspect and is as good as the bone biopsy you get. And think about the pathophysiological process first. before choosing your antibiotics. The duration is for 4 to 6 weeks. It is important to engage our surgical colleagues in the management of osteomyelitis. They can help us drain and debride the wound, remove hardware, provide muscular flap to cover exposed bone, and achieve wound closure. Sometimes adjunct strategies, for example, hyperbaric oxygen therapy and negative pressure wound therapy, which is your VAC dressing, may help. In summary, in managing osteomyelitis, identify the pathophysiological process driving the infection, assess the chronicity of infection, and obtain microbiological diagnosis first before starting treatment. Treatment is based on culture results. It is also based on the pathophysiological process and the chronicity of the infection, and is often multidisciplinary. It involves the use of antimicrobial agents. The duration of therapy depends on source control and how well we have cleared the infection. It is important to debride and reconstruct the affected bone, to rehabilitate the patient, and in cases where there are refractory infections, consider the use of adjunct therapies, for example, hyperbaric oxygen and negative pressure dressing in such patients. These are the key references for today's talk. I'd like to thank Dr. Jenny Loh with the Department of Infectious Diseases for giving me the opportunity to be part of this series, as well as Florida Center of Instructional Technology for use of graphics. Thank you.